Good evening, everyone. Welcome to our Ask the Doctor session tonight. We hope everyone had a safe and happy holiday season. It's great to be back with you guys after a little bit of a break. For those of you who don't know me, my name is Shelly Korean with SkyPass Foundation. And of course, as always, we have Dr. Shilpa Chitnis here as well. Dr. Chitnis, as you guys know, serves on our board and is a movement disorder specialist at UT Southwestern. And we have the privilege of hosting these webinars together, and we're excited to continue offering these free webinars for the PD community. And we are starting 2022 off with a very special guest, with the internationally known and very accomplished Dr. Stanley Fahn, who is here to chat with us about neuroprotective strategies in PD. Just going to read off a quick bio on Dr. Fahn before we get started. Dr. Fahn is Professor Emeritus of Neurology and Director Emeritus of the Center for Parkinson's Disease at Columbia University Medical Center in New York. He retired from Columbia in January 2021 after 57 years of teaching, research, and patient care. In 1985, he co-founded the Movement Disorder Society and was elected its first president. Dr. Fahn has earned several awards and has trained over 130 movement disorder fellows, including many who are professors of neurology around the globe. Dr. Fahn, it's an honor to have you here with us today. I know everyone is excited to hear from you, and the registration numbers showed it. We had a record number of registrations for tonight, almost 200 registrations. So thank you guys again for being here. Feel free to engage with us throughout the conversation tonight using the QA box or the chat box at the bottom of your screen. You can use the chat box for conversation and commentary, and I will be interacting with all of you on there as well. And if you have any questions pertaining to tonight's topic and discussion, you can put those in the QA box, and Dr. Chitnis and myself will monitor that as we go along. And with that, Shilpa, I'll hand it over to you.
Thank you, Shelly. And it's really an absolute honor and pleasure to have Dr. Fahn here. And although I didn't train with Dr. Fahn personally as a fellow, I feel like we have all trained with Dr. Fahn, because over the years I have been to at least tens and 20, 30, 40 lectures given by him. But I have been very privileged that Dr. Fahn started the San Francisco match for the movement disorder fellowships. Prior to that, everybody was disorganized and there was no structure. So thanks to Dr. Fahn, we were able to put together a San Francisco match committee. And I'm just very honored that I co-chair the committee now, and we continue to work with him under his tutelage. So just before we start discussing neuroprotective strategy in Parkinson's, I just want to bring our audience up to speed with what may be happening in the brains of patients with Parkinson's disease, even prior to the development of symptoms. So behind the symptoms of Parkinson's disease, there is a very complex pathological mechanism which leads to a slow dopamine cell loss in part of the brain that's called substantia nigra. And at the time of diagnosis, maybe up to 30% of dopamine neurons, but up to 50 to 60% of their axon terminals have actually perished. And so it's important to really understand the underlying mechanisms and to be able to find a molecule or molecules that can actually protect the dopaminergic neurons from the damaging cascade. So with that, I'm gonna ask Dr. Fahn my first question. So Dr. Fahn, would it be fair to say that even now in 2022, the exact etiology or cause of Parkinson's disease is still unclear?
Yes, well, first of all, before I even answer anything, I want to thank you and Shelly for inviting me. I feel it's a great honor. Even though I'm retired, I love to talk about diseases that I spent my life working on, and I like educating people, and I like to answer questions, and hope that people will understand what I have to say. So I thank you very much for this honor. And you're right. I mean, we still don't really know the cause of, let's say, 76% of Parkinson's disease, because a certain percentage, maybe less than 25%, we know they have a genetic cause. Maybe it's closer to 15, 20%. And so I would say for those known genes, that's one of the big research things that's been in the last decade or 15 years or so, has been discovering new genes that might be causing Parkinson's. And there are a few genes that do cause Parkinson's, so we can say, well, that is the cause. Now, the mechanism of how those genes cause Parkinson's is unknown. And all these other people who don't have a known genetic cause, what is their cause? Most people suspect it's a combination of some small gene mutation, several different gene mutations, maybe plus a exposure in the environment that triggers it. Let's say having the flu. We talked about the COVID disease coming on board in this pandemic. And others even worried about, at least among neurologists, is this going to be a higher percentage of people going to get Parkinson's after this, being exposed and having the sickness of COVID-19. So, I mean, it could be a trigger. Head injury may be a trigger. A lot of different things in the environment might be triggers, and we don't know them all. And a lot of research is going on. Those are called epidemiological research. So there's a lot to learn. And because we don't know all the causes or the mechanisms, we don't have a good way of stopping the disease. And that's where the big focus of research is. And that's what we're going to be talking about tonight. Strategies to protect against worsening of the disease.
Yes, absolutely. And so why has it been difficult to find some early biomarkers for consolidating the diagnosis? And do you see that there is any promising biomarker on the horizon that we could follow that could be potentially modifiable?
Okay. So right now, the diagnosis is still clinical examination. And there are several types of Parkinsonisms. There's even worse than Parkinson's disease is like progressive supranuclear palsy. They have Parkinson features, but it's not the same mechanism, and they have different parts of the brain involved. They're called atypical Parkinsonism or Parkinson plus. But the great majority of all Parkinsonisms are really Parkinson disease. And it's still the clinical exam. And the cardinal symptoms that all the people who are listening in tonight know that the great majority have tremor, there's slowness of movements, and there's stiffness of muscles and so forth, and balance and so forth. What's really bad about Parkinson's disease and all these other Parkinsonisms too is they tend to get worse over time. So we want to catch it early. And the earlier you can catch it, you might, if you had a drug that can slow it down, you want to use it right away. So what biomarkers are, instead of just diagnosing by the clinical exam and seeing how people are doing, trying to find some other tool like a blood test, or even a spinal fluid test, or an X-ray that might help it. And there is technically one biomarker that is quite effective. That is an imaging of the dopamine system in the brain, first by what's called F-DOPA PET scans, positron emission tomography, PET, and now the DAT scans, the dopamine transporter scans. They can image essentially the dopamine integrity in the brain, and that goes down. It's lost in Parkinson's disease. So if the dopamine integrity of the brain is not intact, one could expect they have some form of Parkinsonism. Most likely going to be Parkinson's, but as I said, there are other forms of Parkinsonism as well. So there is something, but that's an expensive test. It's already usually, the abnormalities appear just before the symptoms occur, so you could pick it up before. But people, it's so expensive and it's so cumbersome that people want a simpler test, like a blood test, and then they have me using things like the sense of smell is impaired in many people with Parkinson's before the symptoms. Many people get constipation before the motor symptoms of Parkinson's. And some people have sleep disturbance called REM sleep behavior disorder, where they tend to move in their dreams. This is many people who have that tend to get Parkinson's disease. So there are some hints clinically who might be susceptible, but not the great majority. Even a family history makes one more susceptible. And one might look for their genes. You might find the genes for Parkinson's. So it's not, we don't have a great test. That's true. And people are looking for that. But why is it so difficult? Because what else? We know we can measure dopamine that we're doing with the PET scan. What we really want to do is do another PET scan that measures the compound protein alpha-synuclein, because that's in most cases of Parkinson's tends to be increased in the brain and is maybe a destructive protein. But we don't have a way to measure that by imaging yet. So there's a lot of people working on this, but we're not there yet. I just say there's a lot of papers on it, and even skin biopsies are looking at skin biopsies and things like that. Maybe vision tests, but nothing solid yet. So there's a delay. Anyway, what's going to happen if we get this test? We don't even know how to treat people to prevent the disease. That's what we're going to talk about tonight, of course. But we have to go hand in hand. We want to eventually find that treatment. At the same time, we want to be able to diagnose it earlier with a biomarker. And then once we have both together, we can really do something for Parkinson's disease. That is not to say, for those who already have Parkinson's disease, that even though there are cell loss and neurotransmitter loss in the brain in people with Parkinson's, the disease continues to get worse. So even no matter what stage of the disease you're in, if we have a neuroprotective therapy, you want to be on it and slow it down. Of all the patients I've seen, when I see them in the very earliest stages of diagnosis, they can live with the symptoms when it's very mild. What they worry about is, of course, losing their dependence, having the disease progress. So at any time in the disease, of course, the sooner the better. If there's a treatment that can slow it down, that's what we want to be on.
Yes, absolutely. But how would you know, like, who would you scan with a DAT scan? I mean, is it somebody that has a very strong family history, or is that somebody that's been exposed to pesticides? Like, is there a population that you would scan?
Well, right now, I would say you have to be very judicious about who you scan. For example, we just had video rounds and we discussed a person who has a family history of Parkinson's disease, and the person gets genetic testing and finds that she carries a gene that increases her risk for getting Parkinson's disease. So she wants to know, does she have Parkinson's? She'd be scanned. And her doctor, it wasn't us, somewhere else before she came to us, did this DAT scan. And of course, it turned out to be, in her case, fortunately, normal.
Oh,
but I question whether or not she should have even having that DAT scan. That's
right.
the answer to your question, because what are you going to do about it? She doesn't have any features of clinical features of Parkinson's. There's nothing to treat right now. And we don't have a treatment to slow down the disease or prevent this disease getting worse. So, but if we had that, then why not have that DAT scan? But otherwise, don't do the DAT scan. If you don't have anything to slow it down, what are you doing? The DAT scan is mostly useful to differentiate Parkinson's disease versus something else. To say, gee, is this a little stroke that maybe it looks like Parkinson's, but maybe it's a stroke and not Parkinson's disease? Maybe it's multiple sclerosis instead. It may be helpful in differential diagnosis, particularly something called essential tremor. That's what the FDA first approved it for. The essential tremor patients have a normal DAT scan, while Parkinson's disease has an abnormal one. So if you have any questions or your doctor has a question, they can do a DAT scan and see if they can differentiate it that way. But it's not a massive diagnostic tool right now. It's for the individual case.
Absolutely. I think we should all just start drinking a lot of caffeine and exercise every day. That would be a good strategy.
Did you do that?
I do. I exercise every day and I drink a lot of caffeine.
Okay.
Okay. So just following through the very first neuroprotective study, the Datatop study that was done with alpha tocopherol, which is vitamin E, and siligulin, What is your opinion? Do you think salicylic is neuroprotective? Because there is the older guard. I remember Erwin Montgomery at one of the conferences, stood up and said, "I will challenge anybody who says that salicylic is not neuroprotective." So, what is your opinion?
Yes, you're referring to the Datatop study, which stands for deprenyl and tocopherol antioxidant therapy of Parkinson's. Deprenyl was the name for salicylic before the salicylic name was acquired on it. Why did we do that study? And by the way, that was the first pioneering study to look for neuroprotection in Parkinson's disease. And there were two reasons for that study. One was it was recognized for some time that the dopamine neurons in the brain, and even in normal people, are under what's called oxidative stress. These dopamine neurons are generating reactive oxygen species, and because of the metabolism of dopamine itself, when it gets metabolized, it generates these species, and they're reactive, and that could damage the cell. And a person who's susceptible for Parkinson's, maybe it's even worse. That's one reason. The other thing is because of this oxygen stress, the idea of using an antioxidant was prominent. Should we be using antioxidants? That was one question we were trying to answer with the Datatop study. The other thing about salicylic is that a toxin was discovered called MPTP, which was an organic compound that was synthesized by opioid street drug chemists trying to make an opioid that was not yet recognized by the government, and therefore would not be criminally liable because it wasn't forbidden. When they were trying to make the street drug, one of the synthetic opioid, one of the chemists did a shortcut on a batch, and one of the products of the shortcut was the formation of MPTP, which is a long chemical name. It turns out that people exposed to that synthetic heroin that had the MPTP in it came down with acute Parkinson's, and it was permanent. And scientists then began to work on this MPTP in animal models and in the test tube, and they found out what made the MPTP active and highly specific for the substantia nigra dopamine containing neurons is that an MPT itself is oxidized by an enzyme called monoamine oxidase. It's the same enzyme that oxidizes dopamine in the brain. But what this does, this MPT now is a charged molecule, and it is, because of that change in configuration, it was taken up specifically by a chemical transporter called dopamine transporter, D8. That's what the dopamine transporter scan is, DAT scan. So the dopamine transporter picks up this MPT plus molecule, charged molecule, and that molecule now gets into the dopamine cells and kills those cells. So people thought, well, maybe this MPTP is in the circulation, maybe it's out there in the environment, and people are exposed. And anyway, because if you use an MAO inhibitor, monoamine oxidase inhibitor, like deprenyl, like salicylic, it protects MPTP from becoming toxic and getting into the cell. And so therefore the idea was maybe there's something about MPTP in Parkinson's disease. And the idea was the Parkinson's study group was founded to do this study. And we test salicylic and test an antioxidant, alpha tocopherol. Tocopherol is nothing more than vitamin E. That's the chemical name for vitamin E. So we use very high doses of vitamin E, and we use doses of salicylic, and we did a double-blind trial. 800 subjects, 200 had, anyway, half of the people got selegiline, half got tocopherol, but it was a mixed combination. So, well, it's not really that. A quarter, shouldn't give you the numbers. Anyway, 200, 1/4 of them had double placebo. The others had either the combination of the two drugs or one of those active drugs against placebo of the other. So that's how they got 4/4. And it turned out that selegiline was quite effective. It did slow down the worsening of the disease. It was highly statistically significant. It delayed the need for levodopa therapy by 9 months. And so it was promising. But the antioxidant tocopherol did nothing. It was the same as the placebo, and that was high dose. It turned out tocopherol, very little of it got into the brain. It's didn't penetrate the blood-brain barrier well. So, one could argue maybe a better antioxidant would be better. It didn't disprove problems with the oxidative stress theory. It's just that the drug didn't get in the brain well. But the idea of selegiline came up, is it neuroprotective? And the debate is it just because selegiline or the MAOB inhibitor that it is slowing down the metabolism of dopamine in the brain, increases the level of dopamine in the brain by doing that? And is it just symptomatic? In other words, is it a clinical effect from just having a little more dopamine in the brain? Or is it really neuroprotection? And we couldn't prove it on that study, but it was a hint. And so the next study that the Parkinson's study group did was to take those subjects who were all in the Datatop study, but already now had started the levodopa. It was over 300 subjects of that population. Ask those subjects, would they be willing to do another double-blind trial? Stay on your levodopa. Don't change the dose of levodopa. Take your doctor will treat you as like any other Parkinson's patient with levodopa. But half of you would go on in a double-blind trial. Half of you would go on selegiline. The other half would go on a placebo for selegiline. And that was called the blind data study. That, for some reason, it's not well known. It was published in an extremely excellent journal. But it was such a complicated study, people just didn't understand it, but it was really dramatic. It really showed that if you're on selegiline and levodopa instead of placebo and then levodopa, the disease did not worsen as quickly. You needed much less levodopa as the disease worsened. You need, and the most important thing, because that could all have been symptomatic, people on that combination, now they can have all the levodopa. In fact, the placebo group had even more levodopa. The people who want selegiline and the levodopa instead of placebo and levodopa, their development of freezing of gait was delayed. Now, freezing of gait, which is a very bad feature of advanced Parkinson's, and it doesn't matter if you're on levodopa or not, people get freezing of gait by and large. That freezing of gait means your feet stick to the ground and you have trouble continuing to walk. And it often leads to falls. But the selegiline, so far to this day, of all the other drugs ever studied, no other drugs have been shown to slow down the likelihood of getting freezing of gait. And that's why I have always, since that study, suggested to my patients early on, they should try selegiline. Now, we know selegiline, after all this, the disease still worsens, so it's not a gold mine. The disease still worsens. If it does anything at all, it's a small step. But if you're going to start with something, I always like to start with selegiline because it has that mild symptomatic effect, and it also has this potential protection against developing freezing of gait. Even though over time, freezing of gait it just slows it down. So that's why I use it. Is that hard proof? Well, it's not hard enough proof for the FDA. There are other MAOB inhibitors that were looking at it as well, and one was rasagiline, which is very similar to selegiline. That's another drug, but and that was shown in a very elegant study called a delayed start study design. Again, it's inconclusive whether or not it really slowed down the disease. They tried 2 doses, 1 milligram and 2 milligrams, and 1 milligram seemed to slow it down, but the 2 milligram did nothing. It was the same as placebo. So it was not considered a successful study. And most of us feel that 2 milligram doses, if it was really a good drug, it should have been better, and instead of it wasn't. So we think it was a drug that didn't work. So that's where it is. We don't have a really good drug, even though people use it, selegiline. But I think selegiline is still a good drug, but it doesn't really prove that it's certainly not the wonderful drug we hoped it would be, but it is still a mildly effective drug.
Yeah, thank you, Dr. Fahn. Let's talk a little bit about alpha-synuclein immunotherapy. This is something everybody's talking about. How do you think this works, and do you think this has real potential for neuroprotection?
Okay, so we already mentioned alpha-synuclein once before. That's the protein that's normally found in the brain. It's usually a soluble protein. It's found near the synapses. It helps neurotransmission. For some reason, in about 75% of people or more of Parkinson's, the alpha-synuclein accumulates, aggregates, gets deposited, forms this pathological substance called Lewy bodies, the hallmark of Parkinson's. And it turns out that alpha-synuclein in people with Parkinson's is a rogue protein. It's almost like the prion protein in Creutzfeldt-Jakob disease or Kuru, where the protein, a normal protein, becomes a rogue protein, like a malignant protein. It turns other normal alpha-synuclein into rogue proteins as well, and it keeps traveling, goes from one neuron to the neuron. It progresses up the brain. So Parkinson starts deep down in the brainstem, like in the, and then it spreads upwards. And in fact, Parkinson's is thought to start below the suspension nigra, eventually gets to the midbrain where the suspension nigra is, and it keeps going up, and it goes into the thalamus and the cerebral cortex, and that's what causes the progression of the disease. It keeps spreading, this rogue protein. So the idea is we can conquer this rogue protein, get rid of it, or prevent it from forming. We have a way of slowing down the disease. It's a great idea. And the idea of using antibodies against alpha-synuclein was, let's see if the antibodies don't cross the blood-brain barrier, but if it can get any the equilibrium, if you can take some alpha-synuclein that got out into the peripheral circulation, maybe more will start coming out in the equilibrium, and you might be able to get rid of the alpha-synuclein that way. Now, we have no way of testing because we don't have that alpha-synuclein PET scan yet. And so there were several drug companies, big ones, with lots of money, investing their energy and money into some clinical trials. And most of these have failed. One has a hint that maybe there was a little bit of improvement and not as compared to the placebo group. And so they're still going on with it. So the idea was a good one. It's the same idea that's been used in Alzheimer's disease. You might have read in the paper, even one of those antibodies was approved by the FDA. Even though clinically it didn't do anything, it did attack the amyloid protein, which is a different protein in Alzheimer's disease called amyloid. And it did remove amyloid from the brain, but it didn't do anything for the clinical disease yet. So, I mean, it's still an idea. There are other ideas for alpha-synuclein too, finding drugs that might prevent its formations or rogue protein, and or the consequences of that rogue protein once it forms to prevent the aggregation of these proteins. So there's a lot of interest in alpha-synuclein, and I would say that 55 years ago, we entered the dopamine phase of Parkinson's when the dopamine was discovered to be low in the brain, and we've been using L-dopa ever since to increase dopamine. as a symptomatic therapy was wonderful, great drug. Well, you should see what it was like before in the days we didn't have L-DOPA. But now we're into the alpha-synuclein phase, and we just don't have the drugs yet, but we at least have new knowledge about the brain, which we didn't know before, about alpha-synuclein being a rogue protein. So we just need some breakthroughs in finding ways that control the alpha-synuclein. And that's true with many of the degenerative disease in the brain. There are all these abnormal proteins. Huntington has a normal protein, Alzheimer's has an abnormal protein, and so forth. This disease I told you before, progressive supranuclear palsy, PSP, has an abnormal protein. So, and that's another trick. Maybe how to metabolize that abnormal protein, the machinery for metabolizing it, it might be impaired in Parkinson's disease, and that's why it accumulates. I don't, maybe you'll come to that question later on. We'll come back to that. But anyway, it's a very important target for neuroprotection. It's getting rid of these accumulated proteins in the brain, which have not been disposed properly, like the garbage disposal doesn't work. And if you don't take out the garbage, what's going to happen to your house? That's going to accumulate garbage. Pretty soon you won't have a house anymore, right? Same thing's happening in the cells in our brain that get these degenerative diseases.
Absolutely, thank you. What do you think about, similarly think about growth factors, like GDNF, for example? Is there still, I know that the last study out of UK didn't really show very promising results. So is there still any potential for growth factors in slowing down disease?
Yeah, well, growth factors. So these growth factors are proteins in the brain that increases substances like dopamine, dopamine neurons, keeps them surviving. And so when these were discovered, it was thought, gee, if people can just get these growth factors into their brain, and maybe we can keep these dopamine cells alive. And that was tried. They did put catheters into the brain, into the ventricles, and infused these growth factors. If anything, the patients got sick. They got encephalitis, particularly involving the cerebellum, and they didn't get better. Some people, including placebo patients, thought they got better. And there was a big clamor, and they wanted the drug not to be taken off the studies. But there really wasn't any improvement. I mean, other than probably the placebo effect. And that's why we have to do placebo studies, because placebo patients also get better. And you have to realize that if they're going to get, some people, them are going to get better than some of the people on the active are going to get better just because of that. Anyway, so it was tested, and they tested again. Some researchers who had early experience with it decided not to give up, try it again, and these new studies failed also. So by and large, I don't think we're going anywhere. That the other thing, a problem is we now know we're beyond that phase. Like I said, we're in the alpha-synuclein phase. We know that dopamine is just a byproduct of the cells dying. So just replacing dopamine is not going to stop the disease. And that's going to be a problem with transplants. We talked about cell transplants, stem cells, fetal transplants, and all these. They just replace the dopamine neurons. Even if it takes, it's not stopping the disease from getting worse. And we have good dopa. L-dopa is a very good drug for replacing missing dopamine. That's not an issue. What we don't have is treating symptoms of Parkinson's disease that are not susceptible to dopa treatment. They're non-dopaminergic. The freezing of gait I talked about, cognitive changes I talked about, sleep disturbances, behavioral disturbances, things like that can happen. The balance problem, that's not susceptible to L-dopa treatment. It's not dopaminergic. There's a lot more about Parkinson's disease we don't know. We thought we knew a lot about dopamine, but it's other things is going on as well. So there's a lot more research to be, and people who have Parkinson's disease should donate their brains after they die. What do you need it for? Give it to research. Let us try to find out other things going on in the brain that we can maybe turn into a treatment. Anyway, that's a pitch for the future.
Absolutely, I totally agree, Dr. Fahn. Thank you. What do you think about the anti-diabetic drug Exenatide? It's being developed in clinical trials. Does it have any potential?
Yeah, I think that still has a potential. The early trials, which are not really well designed, they're not great double-blind trials. And that's the problem with open label trials. Almost all open label trials show benefit. They showed some benefit, but the idea behind it was intriguing because these agents, glucagon-like peptide agonists, they relate to diabetes, and they're used to treat diabetes, but they seem to have some effect on cell models of degeneration. And that's why they were looked at. And they did these studies, particularly out of England, which suggested that maybe those who are on this open label drug or a single blinded study did better. The problem is when you analyze the data, they seem to get better pretty quickly, and then it sort of stables out, and they'll keep on getting better. They keep on getting worse slowly, and that suggests maybe it had some symptomatic effect rather than a protective effect. And so there's doubt. But now they're trying to do a real double-blind trial, and we'll find out. And it's very hard to do a double-blind trials in Parkinson's because we have symptomatic therapy. And people, the only ones who are really good, once you're on symptomatic therapy, how do you measure disease worsening? They're on a drug, they're on L-DOPA. L-DOPA's preventing symptoms from appearing, and therefore, how do you know that your active drug that you're testing is good? Maybe doing something with the dopamine, the L-DOPA. So the best studies, I think the best candidates are the very early newly diagnosed patients who don't need any medicine. When you're newly diagnosed, you can get along pretty well. And they're good, perfect candidates for these protective trials and testing a new drug. And that's what they were doing on the alpha-synuclein antibody. They were taking people who were not on L-DOPA and seeing if the disease worsens more slowly than the people on placebo. Anyway, that's the kind of studies we need to do. And that's what they have to do on this glucagon peptide-like drug. And I think they're doing it now. So it's being done in England, it's being supported by a foundation. So we'll see if they do it right this time.
Yeah, thank you. So you mentioned, when we talked about the causes of Parkinson's disease, one of the things that you mentioned is, maybe 15 to 20% of Parkinsonism could be genetic. So to that effect, do you think that the LRRK2 inhibitors or the modulators of GCase, glucocerebrosidase, do those have really good potential in treating patients with genetic forms of Parkinsonism?
Well, I think one of the big advantages of doing these gene studies, not only to find these genes and help maybe get a biomarker and so forth, but you might lead new clues to how to treat. And gene therapy for a lot of genetic diseases is promising. We just haven't gotten there too well yet, but there are new ideas of gene therapy. But one disease, autosomal dominant Huntington disease, was degenerative disease. Everybody who has that abnormal mutation gets Huntington disease. We still don't have a gene therapy for that, but they're working on it, and someday it's going to come. And the same thing can be true for the people who have genetic Parkinson's disease. You mentioned two genes, LRRK2, LRRK2, leucine-rich repeat kinase 2 inhibitor, not inhibitor. It's a protein. It's an enzyme actually. It's a kinase. It takes phosphate and puts it on a molecule. And what people who have this mutation, a fairly good percent of them will get Parkinson's disease. It's not a big percentage, but it's very clear cut. It turns, what is this protein abnormal mutation causing the protein to do? It's increasing its activity. So people are trying to look at inhibitors of this particular enzyme, this kinase. The inhibitors they've tested so far have been toxic, and people can't tolerate it. The treatment is worse than the disease if you take it. So they're looking for inhibitors that are not toxic, and we'll be trying it. There is a lot of interest in that. people who have that particular mutation, who billionaires are starting companies for people to look into and so forth. So we know there's going to be progress on this. To find the right drug is, it takes time, but once you hit it, you get a jackpot, of course. It's even possible, people speculate, that even if you don't have the LRRK2 mutation, a LRRK2 inhibitor may help you, because the mechanism of Parkinson's disease is still unclear, and it may involve something with LRRK2 kinase. And so therefore, if you inhibit that, you might slow down Parkinson's. So it's going to even be tested once they get the right drug, will be tested on people who don't have that mutation. And the other gene you mentioned, glucose ribosydase, GBA in short, is even more common gene abnormality, protein abnormality, a genetic abnormality. And a lot of people have that, but it's a risk factor gene. It's not a causative gene itself. It raises the risk, so it's a high risk. And so people are looking ways, even if you don't have that mutation, if you can find a way to help the turnover of that molecule, you might slow down the Parkinson's disease. The other thing that the discovery of that GBA mutation, what that enzyme, glucose ribosydase, is located in a structure within every cell called the lysosome. What's important about the lysosome? This is where the garbage is taken care of and disposed in the cell. This is like your sink disposal. This grinds up all these abnormal proteins, abnormal lipids and fats and things. It grinds it up. It's very acidic, this little structure in each cell. And this is where the bad tissue that the cell wants to get rid of is sent to be destroyed. And this particular enzyme that's found there is another argument that maybe the disposal system is what's impaired in Parkinson's. And if we're not disposing these abnormal proteins, they accumulate and cause these diseases. So this is a big clue, and people are looking ways to enhance this type of disposal mechanism in the brain. A lot of interesting research, and they're doing that on all degenerative disease, not just Parkinson's. I mean, Huntington's particularly as well. So I think there's a lot of promise there too. But we haven't got we don't know how to do it yet, but we got the ideas. That's what's important first.
Absolutely. And Dr. Fahn, I'm going to ask you one last question. There are a lot of patients' questions, but I want to ask you one last question because I think this is quite relevant, is, looking at repurposed drugs as a priority for neuroprotection. So whether you're talking about, isradipine, the blood pressure medication, or talking about inosine, or talking about nilotinib. And so what do you think about these repurposing strategies?
Yeah, well, you can even mention the Exenatide was that glucagon peptide, like peptide thing. That's a repurposed drug, was a diabetes drug.
Correct.
Repurposing drugs are he's taking a drug that's already approved by the FDA, it's on the market for some other condition, and seeing if it has some effect on Parkinson. Now, how do you choose these repurposed drugs to test? Well, you need a screening device. You need something that's fast, like in the cell cultures, and see if it makes any changes in some model. And that's what they're doing. They're looking for that. The nilotinib thing, which is used to treat certain cancers, leukemias, was looked that way too, because it turns out that one of the genetic forms of Parkinson's disease works with the mitochondria, and this has some effect on a protein that's generated in that mitochondria. It's called c-Abl. So this leukemia drug was found to be effective against that, and they're looking at it. Unfortunately, the clinical trials were not satisfactory. They didn't really show any great benefit of clinical double-blind trials. They failed, in fact, clinical trials. But I mean, the idea of repurposing drugs is very useful. You just need the right scanning tool. And people are looking at repurposed drugs at PSP and other diseases, MSA, these are other Parkinson type of disease, as well as Parkinson's disease. Yeah, sure, that's it's a shortcut to getting a drug on the market. You can test it in humans early instead of having to go through the process of animal testing first, because it's already a drug that's got another market and it's approved for it. That's why it's called repurposed drugs, another purpose. Yeah, it's a good idea, but we haven't got the right drug yet.
Yes, absolutely. And of course, we did a whole big session actually on the role of exercise in preventing, preventing the progression of the disease. So maybe a few words just on role of exercise.
Absolutely. I'm glad you brought it up, actually, because that's when I see a newly diagnosed patient, the two things I tell them about is, well, three things actually. One is exercise. If you didn't exercise before, you got to start now. And why is that? And that's because first, before there were any clinical trials, just general observations. My patients who exercise were doing better than those who didn't exercise. And now there's some clinical trials showing that may be the case as well. It doesn't stop the disease, but they may slow it down a little bit and do better. And certainly for the person's well-being, they're taking charge of the disease. They're actively working on it. But exercise itself doesn't stop the disease. So you still need the right neuroprotective drug. The other good thing about exercise is that the animal models, very important for people to know this. Scientists out of the University of Pittsburgh, couple decades ago, took rats, gave them this MPTP toxin, became Parkinson. Half the drugs were put in plain cages to recover, and the other half were put in cages with wheels and tunnels. And those rats were running around, exercising, playing these things, and the rats in the plain cage just sat there. Then they sacrificed the rats, looked at the brain, and the amount of dopamine loss was much greater in the rats just sat there and did nothing compared to the rats that ran around. And although humans are not rats, as we all know, still it's a lesson we have to learn from it. And I think it may really well pertain to human beings. So I always tell my patients exercise. It's one of the things. The other thing I tell them, if they're not going to go into clinical trial for neuroprotection therapy, go on sledgeling. But if they want to go do neuroprotective trial, they should do that first before they get on something like sledgeling. Otherwise, it'll interfere with their being able to get on that trial. So those are exercise by all means.
Yes, absolutely. And I think I'm gonna, go on to some of the questions that have been, and I think we went through a lot of the questions that I had sent you earlier, and maybe some of the questions that the patients were asking. Is there any benefit to detoxification protocols in PD management?
Detoxification? Like, I'm not sure. You mean like drug addicts being detoxified? I'm not sure exactly what toxin are we talking about. If you had a toxin, let's say you were exposed to manganese, you want to detoxify yourself. You want to take a drug that gets rid of the toxin. Yeah, if there's a toxin, sure, get rid of it. But you have to know what toxins are exposed to. Some toxins in the environment are like cleaning solutions from let's say the dry cleaners or pesticides. Yeah, if you can detoxify yourself, why not? Sure, do it. If you know how to do it. I don't know how to do it, but it depends what the toxin is you're talking about.
I wonder whether they mean something like glutathione.
About who?
Glutathione?
Glutathione. It's not a detoxifier. That's a reducing agent. Oh yeah, glutathione is the brain's. It's a 3 amino acid compound. It's the brain's most important reducing agent against oxidation reactions. We talked about radical oxidative species. Glutathione is the main reducing agent suppressing that. It's synthesized directly in the brain. People who try to get glutathione intravenously, even through the nose and so forth, it didn't penetrate the brain in any of these cases. So they haven't been effective. But if you can increase glutathione in the brain, that's been and they've been looking at other reducing agents as well, besides glutathione, but they don't seem to enter the brain. That's one of the big problems. Yeah, this oxidative stress thing is still alive and well, and the theories of Parkinson's. And so if you can reduce oxidative stress, that's very important effort. That's why the selegiline trial was done, the tocopherol trial, trying to reduce this oxidative stress. Yeah, but we don't know how to get glutathione and increase the synthesis.
Yeah, absolutely. Have you heard about high dose B1 Thymine being used for Parkinson's?
Thiamine?
Mhm.
Yeah, I read about it. I saw there were some things that came out on the web, internet, and I read about it. But yeah, it's certainly an important vitamin. You know, it's vital for life. Thiamine, and in fact, I think you know, of all the degenerative diseases of the brain, the ones we can do the most to both treat and prevent have been the vitamin deficiencies. Things like niacin deficiency, beriberi, thiamine deficiency, with memory losses and so forth. Look at scurvy, you know, vitamin C deficiency. All these things develop when you don't have enough vitamins. So treating with vitamins is great, but you know, there is one toxin, talking about detoxification, that causes degeneration, but that's copper. Too much copper metabolism, too much copper absorption and not enough elimination from the body will cause copper poisoning, and the disease called Wilson's disease is an abnormal metabolism and copper transport, and they get copper poisoning and they get degeneration. You can treat that degeneration and even prevent it if you get rid of that copper. So if you take a compound that finds that copper and it puts it into the urine and gets rid of it, you will remove that copper from the brain, from the kidneys, the liver, and so forth, and you will get a healthy person again. And that's the same principle like vitamins and so forth. I mean, you have a compound that's a toxin and you eliminate it by all means. If we could, and who knows, maybe you can look at alpha-synuclein as the toxin. And if we got rid of the alpha-synuclein somehow, you know, by preventing its formation or eliminating by antibodies or some other trick, yeah, that's the same principle. That principle has been proven again and again. Getting rid of the toxin, you know, manganese poisoning, copper poisoning, and so forth. Look at too much iron in the body will cause some changes. You have to get rid of that iron, and so forth. All these things are clues, but we don't know how it applies to Parkinson's yet.
What about, Dr. Fahn, what about iron chelators? I know deferriprone, you know, I know they're at least trying to study the role of that particular iron chelator. Does it have any promise?
Well, it probably still has some promise. It hasn't been successful so far. Yeah, iron is one of these things that does accumulate in the brain. I would talk about copper and Wilson's disease, but iron does accumulate in the substantia nigra. And we thought maybe an iron chelator would get rid of it, but there's viscerone, and that's there's still some studies going on, but it doesn't seem, hasn't really been proven to be effective so far. And maybe there are better chelators out there, but maybe that's just an epiphenomenon. It's not really the primary thing, and maybe it won't do anything at all. But iron can cause increased dopamine oxidation and cause reactive species formation. So it may play some role in Parkinson's, but removing by itself may not be still sufficient. Still, it's something to be done, just like a little bit. If selegiline does a little bit, okay, so it's not enough, but so at least something. It's, again, if an iron chelator can do a little bit, you know, maybe it's these little bits will add it up together, will do a lot. So it's still worth pursuing, but it hasn't really been found to be effective yet.
Yeah, absolutely. Are you familiar with the smelling Parkinson's disease new metabolomic biomarker for PD, a related paper, sebum from the upper back analyzed using a mass spectrometer hyphenated to an odor port reveals a unique volatile aroma associated with PD smell, useful for diagnosing PD non-invasively, suggests that perhaps there is a good biomarker in the near future. What do you think about that?
Okay, I'm trying to, is this, you sent me a list of questions. Is this one of the questions?
No, this is from a patient.
Some a patient. So I'm just trying to understand the word again. What was the compound again?
So no compound per se. I think that I'll simplify the question, Dr. Fahn, is like, is there any role for like a sebum from the upper back? Like, is there some kind of a compound that you could smell? If you remember, there was this thing that came out about this woman who would
Yes.
just basically
Smell
smell
who
people,
has Parkinson's, an aroma, yeah.
Yeah. So is that a biomarker? Is there a role for
Oh,
something?
why? I guess, yeah, I guess if there was true aroma, and this woman says she has the ability to do that, yeah, that would be a biomarker. It may be too late. In other words, if you already have Parkinson's, what do you need to have a smell test for? You can do it like cooking the patient. What you want to do is test the patient before they have the clinical Parkinson's, and then that's what a biomarker is really needed for it. But if they can do this from a smell or breath analyzer, yeah, that will be a simple test. I read somewhere in the newspaper, I think the New York Times, just this week, somebody developed some kind of smell detector that pick up sensitive smells and write them on a scale, a quantitative scale. Maybe there's something in Parkinson's as smell, but I think just because one woman can do it and nobody else can, I don't know how good that's going to be. We need a machine or something.
Yeah.
If there really is something to it.
No, absolutely. So somebody wants to know, as Parkinson's moves into the mid and the later stages, it seems to be very challenging effects on other systems, cardiovascular systems, digestive and urinary systems. What neuroprotective strategies might help us manage the non-motor aspects of the disease?
Okay, so a lot of the non-motor aspects are in other words, probably non-dopamine aspects also. Behavioral changes, sleep changes, these mood changes, of course, the cognition change. I would say the cognitive change that many people who have the alpha-synuclein form of Parkinson's disease, it's a very serious problem in the late stages of Parkinson's. That's what everybody wants to avoid. And that's why we have to slow the disease down. And alpha-synuclein is a major contributor to that. So finding these are because other parts of the brain besides the substantia nigra, which contains the dopamine, the basal ganglia and the substantia nigra, these other parts of the brain are being affected as well as the dopamine cells. And so it's just treating dopamine. That was the problem with transplants. The problem with just L-Dopa alone. The problem, even genes that just work on the dopamine system alone, is insufficient. You have to treat the pathology of the disease, the underlying pathogenesis of the disease. And who knows, maybe alpha-synuclein alone isn't the answer. It's certainly not the answer for 100% of the cases of Parkinson's disease, maybe about 75%. But there are some forms that are caused from abnormal mitochondrial metabolism, genetic forms. The mitochondria isn't metabolized. Again, it's clogged up. It's not being disposed of, and this phagocytic property of the cell to get rid of these large abnormal mitochondria and these genetic causes that cause mitochondrial changes. And maybe the mitochondrial changes are common and non-genetic forms of Parkinson's disease. And so we need a way to control that. And so there's a lot of other things that can be done besides just alpha-synuclein. We need obviously more research on Parkinson's, but maybe it's going to be a combination of things we're going to have to use eventually to really conquer this disease and slow it down. I was hoping to be able to see we have real progress before I pass, but I'm getting closer and closer to passing. So
please don't say
researchers
that.
got to work on it.
Please do not say that. We need you, Dr. Fahn. So somebody wanted to know about the role of infrared light. I did come across, I was looking at clinicaltrials.gov and some, clinical trials. So there's a role of infrared endoventricular elimination for neuroprotection in very early cases of Parkinson's disease.
Yeah, very interesting. I didn't know anything about it. I saw that on your list of questions, so I had to look it up. in a town called Grenoble, France, in the foothills of the Alps, which was a pioneering center in Parkinson's disease for deep brain stimulation. Dr. Benabid was a nurse there, and he developed this technique. Anyway, some of the scientists there in the Parkinson's research group saw in some cell models of degeneration this factor related to the infrared spectrum of light seems to have slowed down degeneration. And so they tried this in animal models, an MPTP animal model, and they put in a source of this light into the brain of these animals, and it seems to slow down worsening of the disease. And so they're going to try it now in humans. These are going to not be early patients. These are going to be more advanced patients on levodopa. It may be a little difficult to know if you really slow down the disease because they're already on treatment, symptomatic treatment. So that may be a difficult problem. I think that put something into the brain of very early patients when they're really otherwise in very good health is a little risky, especially for something that the safety factor. In fact, what these early trials are is really a safety study to see if it's safe to put these light sources into the brains and the ventricles of people with Parkinson's disease. That's why they're using advanced Parkinson's disease. It's very interesting using advanced patients. You probably all read in the newspaper about this pig that was genes were changed so it would accept human tissues, or the pig tissues could be implanted into humans. And the one man who got a heart from a pig, this genetically modified pig, and the man is still alive after several weeks. He was a guinea pig, but the first patient who was a guinea pig was not that man. That was the first one who got the transplant. It was a man who got a kidney transplant from these pigs. It was a man who was in kidney failure, but was already brain dead. No, it wasn't kidney failure. He was a man who was brain dead. So he's going to die anyway, and he's not alive. He's basically not alive. He's in coma completely, and he's not going to survive ever. But the family allowed his body to be used as a guinea pig to see whether a kidney from this pig would stay alive in this man, and it did stay alive. So he was used. This is a real guinea pig man, an experiment, and the family let that be tested. So that was successful. The kidney stayed alive. Now they plan to transfer this heart, and a real person who needed a heart. And so, this is how science progresses. You have to take some, that's why you have to use these animals first. You have to first see if the device is safe in a far advanced patient with Parkinson's, where you try it on a person who has no symptoms. So we'll see where this leads. I mean, it's an interesting thing. There's a company has developed some kind of a light treatment for Parkinson's disease. It's a sort of a blue light, and they look at the light, or they have it shine on the patient for several hours a day, and they think that might reduce the symptoms, or who knows, it might slow it down. So they have the FDA approval to do tests on these people now with just a light. So there's a light. So the light therapy is another, and look how simple it is compared to a drug. Maybe it'll seem simple. Get your sunshine, right, and see what the lights do to you. Get out there.
Dr. Fahn, I think you kind of answered this, but I'll ask you this again. The role of stems. I think everybody is curious about your opinion on the role of stem cell therapy for treatment of Parkinson's.
Yeah, well, I think what these stem cells are doing is to replace the missing dopamine. And as I said before, just replacing missing dopamine alone is more of a symptomatic treatment than slowing down the disease progression. We've left the dopamine era, and now we're in the alpha-synuclein era. So we have to concentrate on the next step, progression of the disease. Yeah, I mean, as a symptomatic therapy, it may be effective. I think proof of principle, we sort of showed that with fetal tissue transplants. People who can respond and the tissue grows, you can replace their dopamine therapy. They don't need L-Dopa anymore. L-Dopa therapy is not necessary. But they have side effects too. One of the big side effects of these transplant studies, how do you control it? They may produce too much dopamine, and then they get dyskinesias all day. That's what we found in the fetal tissue transplants. Too much. So what's the regulation? At least the cell has its own regulating system. But what's going to stop these cells from overproducing? People worried about these cells becoming cancer, but making too much dopamine is not good either. Too much is just almost as bad as too little. So you have to have a control mechanism. Some ideas of gene therapy is to have a gene that requires some L-Dopa to generate more dopamine, and then you can just deprive them of L-Dopa. They won't produce too much. So there may be a control mechanism that way. And that study has been tested. I don't know where it's going. It wasn't successful by itself so far. That's the ProSaven study. But people have these ideas. That's wonderful things about researchers who are thinking about the things they can do, and then they have the money, they can study it. If they can do it safely, it at least brings in new knowledge, and there's another, who knows where the big winner is going to come from.
Absolutely. Somebody asked an interesting question. What do you think about intermittent fasting and keto diet for Parkinson's?
Repeat that.
What do you think about intermittent fasting and the keto diet for slowing?
Keto diet. Oh, the diets. Oh, I don't know about keto diet. I mean, the gut-brain axis. A lot of people speculate that why is the first pathology of Parkinson's disease in the area of the lower brainstem and in the nose? The first change in pathology. And that they speculate that for the nose, maybe it's something they breathe in the atmosphere that might be a cause of Parkinson's, or one of the factors that cause Parkinson's. And the lower part of the brainstem is where the nerve cells from the gastric intestinal tract come up to the brain and or come down from the brain. In other words, a communication pathway, and therefore something from the gastrointestinal tract may travel up these nerve cells and deposit in the brain and cause these problems. So they're looking at that as a possibility, and there may be something to it. Certainly, you don't want to leave any stone unturned, and people are still investigating it. What about a diet? We don't know the diet per se. People, I would say that's one of the more common questions I get asked from most patients. Is there anything they can do with their diet? The only thing that's been shown in a double-blind trial, or some kind of maybe it's not a double-blind, maybe it's an epidemiology trial, is the Mediterranean diet, where they have a lot of fruits, a lot of nuts, a lot of olives, olive oil, red wine. They seem to do better, less Parkinson's or more mild Parkinson's, and maybe there's something to it. So changing the diet that way. People talk about too much protein. Red meat makes it worse. I'm not sure what a keto diet is. I think it's red meat though, isn't it? I don't think that's particularly good for one, as far as I know. I'm not a nutritionist, so what I say about that is you take it for a grain of salt if you want. Those are very difficult studies to do. They're more epidemiology. What does every person remember what they eat? But there are some prospective studies, and more fish and less meats and so forth. But the vegetarians will get Parkinson's disease. I mean, it's not the answer we want once you have Parkinson's, or preventing it, but it may help things, just like not being exposed to pesticides, cleaning, dry cleaning solutions and so forth. Yeah, you take your safety risks. You don't get exposed to COVID if you don't want to get COVID, right? Same thing. You get the more you're exposed, the higher the risk is. So that you have to think of all these kinds of things as risk factors mainly.
Yes, absolutely. Shelley, what do you think?
I think this is great, but we do have a ton more questions, and I'm sorry, you guys, that we may not be able to get to all of them today. Thank you so much for engaging and interacting with us. Shilpa, if you don't mind, if we could address William's question about the long-term impacts of high cadence bicycling, because that did come in from a few different people. So I know it's a topic of interest.
Oh,
We can
sure.
address that and one more, and then we'll wrap it up. Thanks for sticking with us.
Okay. So Dr. Fahn, what do you think on about the long-term impact of high cadence bicycling on PD?
High impact bicycle riding, is that what you said?
Yeah, long-term impact of high cadence bicycling. Let me read the question again. So what can you tell us about J. Albert's research on long-term impact of high cadence bicycling?
Oh, high cadence bicycling. Yeah. So bicycling. Yeah, that was an interesting study that was reported where he gets, stationary bicycle gets behind it, makes the person do more. Yeah, that's some kind of vigorous exercise. Seems that he has some data to show that it improves, and it may be something to it. It's very hard to do a controlled experiment because and any of these exercise things, and some people have some other kind of high impact exercise like treadmill running or other things. Look at if you can do it, I have more power to you. Not everybody can do all that, but if you're good, I have had. By itself, it's not going to be the entire answer. I can tell you about a patient who happens to be an orthopedic surgeon, a patient of mine, who was a pentathlon superb athlete who won many pentathlons, bicycle, swimming, running, all these other things, in great shape. And he does this, and he has Parkinson's. And he ended up having to have deep brain stimulation. I mean, he can't do orthopedic surgery anymore. He can do medical practice orthopedics. But because of his tremor and everything, he can't do the surgery. And he got Parkinson's, and yet he's a superb athlete. So it's not so clear that it's not going to stop the disease, and it's not going to control the symptoms completely, but it may certainly be another factor. We talked about exercise before. Nobody really knows for sure what is the best exercise. Most people think resistance exercise is better than passive exercise. And so if that's the case, I think we should do it. Do resistance exercise. It may not have to be bicycle. It might be something else. Boxing. That's why boxing became so popular. You're doing something, but I still see people getting worse. It doesn't stop the disease. But people, it may slow it down in a way or keep the symptoms from getting too worse too quickly. And it's certainly worth trying. And it's healthy for your whole body anyway. So why not do it? But by itself is probably not going to be the answer we want with a simple pill to take, right? I mean, but it certainly is something to do. Yeah, I'm all in favor of that.
Wonderful.
Shilpa, we have one last question on Rytary, which also came in from a couple of different people. So I think we can address that. Let's see. It says, as a known expert on Rytary, what can you share about the potential conflicts between the slower acting beads and the protein from a meal 1 or 2 hours after taking Rytary? Similarly, what happens to Rytary beads in the context of slow gut motility? In other words, if it never reaches the brain, does it count?
Okay, so people should know Rytary is a slow releasing levodopa compound. So by itself, it wouldn't kick in so fast. So it's combined with rapid release levodopa together. So they gave the name Rytary to it. And then there's another version coming out, which is even slower. Yeah, there's great. It's certainly for treating symptoms. It's levodopa. Just basically, it's levodopa. It's going to treat the dopaminergic symptoms. What it was certainly shown to be very useful for people who have what's called the wearing off effect. That is, where your levodopa dose doesn't last long enough, and it starts to wear off, and you have to take another dose. So a slow release levodopa, which is what this is actually targets a combination of some quick release and slow release together. It tends to reduce the severity of those wearing off effects. And as I said, there's newer versions coming out, which even is slower, and that might be good because it's not fully absorbed. See, the absorption of levodopa, although levodopa is an amino acid, it's a very special amino acid. It's only taken in the diet. It's formed in the body. It's not taken in your diet. Normally, you don't have levodopa in your diet. There's only a few beans. The velvet bean, for example, is one of them. Is another one that may have some levodopa in it. But most of your levodopa is generated in the cell itself by an enzyme called tyrosine hydroxylase from another amino acid called tyrosine. But you use L-dopa all the time. You take it by mouth when you're treated with Parkinson's, for Parkinson's disease. And that's what Retari is. It's a combination of rapid and slow release levodopa. And it's certainly good for wearing off. But you have to know how to use it. It's tricky. The dose is not worked out as well as quick release levodopa. And so your doctor has to be experienced in knowing how to do it. And I don't want to get into how to go into the treatment with it now. But what its promise is, can it do something else for clinical thing? Can it really slow or prevent the development of these wearing off and dyskinesias? And that really hasn't been studied properly. And the drug company that makes Retari never did those studies. But it's on the market. And when I have a young patient now, like they're in their 30s, and I know they're going to get dyskinesia and wearing off, I'll switch them to Retari like drug, a slow release, chronic levodopa in the bloodstream and in the brain, and maybe it'll help them avoid these complications. So it's mostly for treating the complications of levodopa therapy. It doesn't have anything to do with slowing down the disease progression. Nothing to do with pathogenesis of the pathology, but might be very important for treatment of the symptoms. And there are other ways, there's other things that are being tested, drug patches through the skin or in the bloodstream directly, and or infusions of dopamine agonists, all kinds of things for treating complicated. But tonight's topic is on strategies for neuroprotection and progression of the disease. So we really should stick to that, I think.
Absolutely. All right. Well, Dr. Fahn, thank you so much for your time and expertise. Sure, everybody learned a lot and enjoyed. Shelley, over to you.
Yes, thank you so much, Dr. Fahn, and thank you to everyone for staying with us. I know we went past time, but we have so many, well, first of all, so many attendees, a record number of attendees, and so many great questions. So we tried to address as many of them as we could, and I know we didn't get to all of them. If you did not have your question addressed, my sincere apologies. We will try to address them via email if we can over the next couple of days. And this session is also being recorded and will be put on our YouTube channel by the end of the week. So if you know anyone that you think could benefit from this information, or perhaps if you would like to watch it again, feel free to do that. I will be sending out the link to everyone that is registered by Friday. And a special thank you to our international attendees. We've got people from Guatemala, from Brazil, I think a couple from the UK that have joined us tonight. Thank you so much for joining us, and we hope you enjoyed tonight's session. And with that, we will wrap it up. Thank you again, Dr. Fahn, so much for your time.
And let me say, I enjoyed it also.
Wonderful. Thank you. We appreciate
it.
Very good question, Shilpa. Thank you very much for asking.
Yes. Thank you, Dr. Fahn, and hope to see you in, are you going to come for AAN in April?
I'm signed up to go to Seattle in April. We'll see how the COVID hangs on or not.
Yeah.
Right
How is retired life?
Oh, I'm getting used to retirement now. I still go on Zoom meetings and video rounds and read the literature, but I don't have the urgency anymore. I sleep a little later every morning.
Absolutely,
it's,
you deserve
I
it.
don't have the pressure like I used to have when I had to get up and see those patients.
Yeah,
It's,
I look
it's fun
forward to that.
retire. Being able to retire is good. I decided it's not so bad after all.
Yeah, no, you.
But I was going to die with my boots on, but I have a few years left to relax a little bit.
Yes, absolutely. Enjoy every minute of it.
Okay. I like doing this. Thanks a lot for asking me.
Sure, absolutely. Thank you for joining us. Thank you, everyone. Have a wonderful rest of your week. And if there's anything we can do for you, please feel free to reach out to us. And we will see you guys next time.
Okay.
Have a great night.
Bye-bye.
Good night.